Thank you, Dr. Sahadullah, Dr. Matthew, the esteemed speakers, and the amazing Caho team for inviting me here as a keynote speaker. It's really an honor and a privilege. I'd also like to thank everyone who spent time coming here today and spending your weekend learning about how to advance patient safety. It's great to see such passion and commitment for advancing knowledge and the service that we provide to our patients. What I'd like to speak about today is how can we sustain the amount of effort, investment, and time that we put into focusing on improving patient care and outcomes. Sometimes implementation is very difficult, but the most difficult part after implementation is ensuring the sustainability and long-term success of all the activities that we implement. So what I want you to think about is how can we avoid the ups and downs, the stops and starts of a roller coaster, for example, and make sure that we have an upward trajectory, an ongoing implementation of the benefits of all of our work in patient safety and quality. Across the work that ACHS International has done across Australia, the Middle East, and Asia Pacific, what I'd like to share with you today is the top 6 challenges that we have found in terms of sustainability of patient safety and quality implementation, and share with you some best practices that we've seen from healthcare providers around how sustainability can be implemented and supported. The first one I'll start with is staff engagement. So staff engagement is to ensure that we are creating a motivated, passionate workforce that is owning the implementation of patient safety and quality. So best practices that we have found are boiled down into 2 simple concepts. One is subsidiarity, and I know many of you are from Catholic healthcare providers, so I think this will be of key importance to you. Subsidiarity basically is that if you are going to affect change in an organization, make sure that those individuals who are directly impacted by that change, most likely frontline workers, are involved in owning and engaged in creating and implementing that change. The second, if you are aware of Lean Six Sigma, this concept of going to Gemba. It's a Japanese word that means the real place. Basically, the concept is that if change is going to be implemented, you should actually go to the front line of where that change is going to happen. So on a ward, in an operating theater, wherever in a healthcare facility that change may be occurring. Now, to put these concepts into a real-life example, I'll share with you a program that I worked on in terms of patient safety improvement. We had an issue where a lot of our nurses were racking up considerable overtime within a hospital surgical ward. And we found that that was leading to burnout, lack of motivation, increased call-outs of our nurses not being able to provide service. When we spoke to those nurses, we found that they were, in addition to their clinical duties, a considerable amount of time doing extra administrative work. What we wanted to do was that we wanted to decrease that overtime, ensure sustainability of our nursing workforce, and ensure that our RNs were working to the top of their license, ensuring that all the specific knowledge they had, that they were applying that to patient care. So what we did was a Lean Six Sigma project, but instead of driving it from the top down, we said, here are the resources, the investment, the time and opportunity for our nurses to be engaged and think about how they drive that improvement themselves. What the nursing staff did was they did spaghetti diagrams to figure out how much time they're spending walking around a ward, spending time doing non-value-added nursing activities. We gave them investment and support to then figure out how they invested and implemented quality improvement activities, like reorganizing small carts outside of each patient room that had high frequency of consumables, so they didn't have to waste time walking back and forth to storage rooms. That was one of many improvements that were made. What we found was at the end of this project that there was an increase in terms of value-added nursing time from 42% to 67%. Now that was a great outcome from our implementation, but importantly we wanted this to be implemented. Now 6 years after this project has been completed, we find that the nurses are still passionate about the work that they're doing. It was because the CEO and the leadership didn't push this project on them. The CEO and leadership gave the nurses and staff on the ward the opportunity to think differently and had them own the change. And they owned that change continuously after it was implemented. So this is a small but useful example of how staff engagement, ownership, and motivation can really drive sustainability into the future. The second challenge is data and analysis. So once you implement, you need to ensure that is that implementation working to drive continuous improvement? Now, what we see of organizations that do sustainability well is a relentless focus on data and outcomes and analyzing that data to figure out what they're doing, how what they're doing is telling them, and how they can change. However, data in healthcare is obviously very difficult. Some of these key difficulties to watch out for are collecting data based on paper systems, hybrid systems, or electronic systems. I'm sure all of us know these difficulties very well. Standardized collection, no capacity to collect, drowning in data. Sometimes we have too much data and it's very difficult to find trends. Answering the question, does measuring data actually translate into better patient safety? And assumptions that just by monitoring data, someone else will make change or respond to that data for us. The third area is feedback and communication. Now, I think all of us have heard Drucker and Deming talk about you must bring data to drive change, or what gets measured gets done. But a quote that I like to focus on in terms of sustainability is Johnny Jones's quote, which is, what gets measured gets done, but what gets measured and fed back gets done well, and what gets rewarded gets repeated. So this is the ACHSI quality cycle on the right-hand side. And you can see at the center of all of the outcomes, the measurement, the evaluation, is feedback and communication. Feedback and communication to all of our frontline staff about why you're collecting data, why you're implementing projects, what is the outcome of that improvement, is really important to close the loop around you are having an impact and what you're doing is making change for patients. The fourth area is knowledge and technology. So this is really interesting data around the amount of time that medical knowledge takes to double. In 1950, it took 50 years for the amount of medical knowledge to double. 1980, it took 7 years. 2010, 3.5 years. 2020, 73 days. 2022 and beyond, who knows how quickly all of the knowledge will take to update. Now, it's impossible for human beings to stay on top of the vast amount of change in data and technology, particularly in health. So what we've seen in terms of data and implementation sustainability is clinical decision support tools and change management to help our frontline workers ensure that they're staying up to date with the latest in data and technology and knowledge to drive patient improvement. The fifth area, which we talk about considerably, is leadership and commitment. So these are just a quick summary of the key components of leadership that we find to be supportive in driving sustainability. One is visible leadership. So coming out of the office and wherever the administration department is to showcase support for quality improvement. Second is active listening. Listening to understand, not listening to respond. A questioning attitude. Resource redirection. Redirecting investment and time and effort to areas that will make the biggest impact. Non-hierarchical decision-making, trying to create a flat structure where everyone has a say about what is required for implementation and sustainability. And a final concept of constrained improvisation, which means that leadership, just like my example with the nurses on the surgical ward, gives some flexibility and space to think differently in the areas in which they work. And they're supported to do that and encouraged to do that. The sixth area is human factors. So the factors in which we place our frontline workers in an environment. The environment sometimes that we have in healthcare is designed to almost make mistakes, or inevitable environment to make mistakes. And this is a prime example that we see in medication management with look-alike, sound-alike drugs like that you can see on the screen. So what we need to focus on in terms of sustainability and reduction of error and improvement of safety is human factors that recognizes the workplace needs to be designed and organized to minimize the likelihood of errors occurring and the impacts those errors have when they might occur. This is to get to the concept of changing from a blame culture about when mistakes occur on the individual to focusing on a just culture of maybe we're actually putting our workers in an environment that supports them to make mistakes instead of supporting them to drive improvement. And this leads to some other barriers that we've seen as well in terms of driving sustainability. The first one is unrealistic expectations of clinical perfection. Sometimes we think healthcare professionals should not make mistakes, even though we're all human at the end of the day, and mistakes are a part of normal life. Also, the litigation and regulation that has grown up in many parts of the world, sometimes to an extreme degree. This then changes our focus on not looking at the environment of human factors, but instead looking at individuals as the source of an error, which we know culturally is not very conducive to sustainability of improvement. This leads to shame, reluctance to report, and then ultimately a slowdown or reversal of all the improvements that we make in our quality programs. I'd also like to share an organization that we partner with in Australia called BPA Analytics, which has really focused on a useful way to think about safety cultural measurement. They've come up with a model called the types of culture, where they survey staff, they survey patients, they survey the community around the culture of safety at a particular organization. And they simply map it on this great graph that you can see here in a way that goes from a culture of blame plus a culture of reaction, consolidation, ambition, and success. Basically, this means at your organization, are you moving from sustainability of blaming individuals to a culture of supporting success and celebrating that success across the organization? So I'd like to wrap up with a staged journey. Change in culture and change in sustainability doesn't happen overnight, although I'm sure we'd all love it to happen that way. This is what we see as sort of the progression of an organization in terms of their maturity in culture, their maturity of safety, provision, and their maturity in terms of sustainability support. This actually comes from an example outside of healthcare, so I always like to look at other industries outside of health and how they think about sustainability and safety improvement. This model is actually from the International Atomic Energy Agency, the agency that looks at and assesses the safety of nuclear power plants across the world. Obviously, we want those to be safe so we don't have major disasters. What they have boiled this down to is that a three-stage process. The first stage is that organizations focus on safety management because it is pushed upon them. It is based on rules and regulations. They must focus on safety because of accreditation. They have to focus it on for payment from insurance companies, or because that is just the law and regulations of their country. So that is the very basic starting point. What we want to get to is stage 3. Stage number 2 is where, without external pressure to focus on safety, the organization makes safety a goal and focuses on organizational goals of safety and performance. As I mentioned, what we want to get to is stage 3, where safety performance is dynamic and focused on continuous improvement. Even if you've implemented a variety of patient safety improvement projects, you have the culture around supporting success, that questioning attitude of what else can we do every single day, even if it's small, to make improvements for our staff, our patients, and our community. So I'd like to wrap up there and say thank you everyone for listening. Hopefully I've been able to share some useful information around sustainability, improvement, and patient safety and quality. And I wish you the best and a great and wonderful learning experience in Cahocon. Thank you very much.